With great pleasure, I get to sit with Dr. Kyle Saikaley, emergency medicine physician, as well as he then completed a one-year chronic pain fellowship through McMaster. And you have a special interest in headaches. And I've been trying to get you to sit down with me on this chair for the last little while, but you've been kind of evading me a little bit.
I'm
So
camera shy. It's camera shy.
I finally get to sit down with you and talk about, a pain pathology that, is quite prevalent and has significant implications for people.
Yeah.
So, when I started my pain fellowship, I did my pain fellowship, as you know, at UBC. My program director, whose background was psychiatry, had a special interest and was an expert in migraines. So I got a lot of exposure to migraines. And one of the things that really stood out to me was, we all know about back pain. Back pain is, the most common cause of pain in general. But migraines are quite prevalent, and they affect young people, and they most commonly affect young women. And so I remember when I was doing my training, it was women between the ages of 18 and 40, 18 and 45, and they develop migraines, and migraines, as you know, can become chronic. And chronic migraines significantly affect women in their most productive years of their life. And that's something that, really dawned on me, where I was like, I'd really like to see better migraine care. And it comes back to all the things, a few years into practice, is the access to care. So I'm hoping that, you can help connect some of the dots to migraine therapy. So why did you specifically develop a special interest in migraines and headache just in general?
Yeah, it's a good question. My first exposure to migraine in my training was I had done a neurology rotation in Ottawa, and so I worked with some of the big folks in the headache and migraine world in Ottawa. And before that, I really had no idea that there was this whole subculture around migraine and headache, medications that I didn't even know existed. But at the same time, I had realized that, oh my God, like I'm going to consider emergency medicine primary care. So in primary care, migraine is very much underdiagnosed and undertreated. And so I felt that there was this big need in the community
Yeah.
To utilize some of the new medications. Like it's a strange thing to say, but it's for someone who has migraines, now is kind of a good time to have migraines, given all the new therapies that are coming out and have come out over the last few years that weren't present decades ago. So all that tied together was kind of how I fell into
So
it.
migraines are interesting because, we have, Canadian guidelines, American guidelines. And so can you just kind of tell us, so there's a lot of misconception, what actually is a migraine? Obviously there's criteria. So even in my practice, I don't see headaches. Actually, I don't see headaches at all anymore. But sometimes I'll have patients tell me, oh, I suffer from migraines. And then when you actually ask them about it, it's not really migraines. There's different classifications. So what's kind of like in your consultation with a patient, what are the main questions that you're looking for to see if they're actually having migraines?
Yeah, so there's a very strict definition of episodic and chronic migraine. If you follow the ICHD-3 guidelines, they will have in there a very specific sort of list of things that make someone sort of meet the criteria either for episodic migraine or chronic migraine, or episodic with or without aura. But really, my big questions are, how bad are these headaches? So oftentimes, folks can get more mild migraines or more mild headaches, but typically those with migraine disorders will get a headache that is quite moderate to severe, knocking them out. They're missing work. So I ask around the functional aspect of it. And then there's the nausea and vomiting. So oftentimes folks with migraine will have associated nausea or vomiting, not always. And then there's the classic light and sound sensitivity, which, for folks with something like tension headaches, may occasionally get fluorescent lights that are bothering them. But for folks who have migraines, the nausea, vomiting, sound sensitivity, and light sensitivity are quite prominent. along with the um, sort of moderate to severe nature of it. So those are the major questions that I'm asking to distinguish whether or not something is a migraine or not.
Right. And then so another thing that, I really come to appreciate with pain in general is that acute on chronic and then that chronic part of chronic pain.
Yes.
And so whether we're looking at migraines, headaches, or back pain or knee pain, what we really care about as chronic pain and interventional pain physician is kind of snipping that period of going from that acute on chronic to chronic pain. Because as you know, the social implications, the healthcare utilization, just the general utilization to the entire public for someone who goes from an acute on chronic to a chronic
Yeah.
is something that we kind of really have to stop. And so, what's kind of your approach to that in migraine headaches?
Yeah. So I'm glad you brought that up because the natural history of migraine is to progress from episodic to chronic or acute to chronic. But then in the migraine world, they call it episodic. And then once, this is a bit of an arbitrary definition, but it is ICHD-3 guideline definition. Once someone is having 15 or more headache days in a month, 8 of which have to be or meet criteria for migraine, then you're in the chronic territory.
Okay.
And so the natural history of migraine is to go from episodic to chronic if left untreated.
Yeah.
And so just like back pain, just like radiculopathy or any type of acute pain, if left untreated long enough, may progress to chronic. And so, of course, you want to get on top of things sooner rather than later so that you can prevent it from progressing from episodic to the chronic state. And so, I think that in primary care, I'm seeing a lot of family physicians who are starting to prescribe preventive medications, which we'll talk about in a little bit, but preventive medications and acute medications, and I think that's fantastic. But I think the message that I would get out there for those who do have what they think are migraines is to speak with your family physician, speak with a headache specialist, so that you can kind of catch it before it gets really into that chronic phase.
Okay, so for the viewers and for the general public, it's really 15 headache days. Whether they don't have to necessarily be migraines,
Correct.
It can be any type of headache, right?
Correct. 8 of which have to be migraines.
8 of which have to be
Yeah.
migraines.
Again, I don't know how they came up with that. I'm sure if I looked at the appendix of some of these papers, it would explain why, but that is the definition of chronic migraine.
And so as we know, we're talking about acute on chronic pain pathology. When things become more chronic, they become more resistant to treatment.
That's correct.
So it's really important for them, for patients who are suffering from migraines, to really get specialist-led care, or initially make contact with their family physicians or their primary care physicians, and then have specialist-led care.
Correct.
What's your kind of pathway when you see, I saw migraines early on in my consultant career, and they're very disabling. They really affect patients' quality of life.
Mm-hmm.
They can result in trauma to patients, fear of patients. They get anxious. They can develop depression. And as you know, at Afiya, we really care about the holistic part of healthcare, right? So we're not just interventional pain physicians. We start patients on pain medications. We talk about supplements and things like that. We talk about getting them into our pain classes, giving their confidence back. What's your kind of pathway with one of your typical migraine patients that you see on a day-to-day basis?
Yeah, sure. So I'll specifically talk about the non-interventional side of things because you were talking about medications, but even the other like lifestyle factors and pain classes like you talked about. So oftentimes when I'm meeting with a patient who has migraines, I'll start off by talking about lifestyle factors. And the truth of the matter is that most of my patients who have migraines are already very good at doing all these things anyways, but I just sort of remind them just to reinforce the fact that it's probably going to help. But it's things like limiting the amount of caffeine you take, so trying to keep it under 2 cups of coffee a day. Sleep hygiene, super important, so trying to keep the same bedtime and wake up time, keeping that consistent. Keeping hydrated throughout the day, sticking with 3 meals a day. I know it sounds silly, but it's super important, and it's been found to, over time, probably contribute to worsening of migraines for folks who, skip out on breakfast. I'll often tell patients to increase the amount of protein they're having at their breakfast meal, and then trying to identify triggers as well. Everyone has different sets of triggers, whether it's chocolate or red wine or the weather changes, which unfortunately there's nothing you can do about. But learning what your triggers are and trying to avoid them is part of the sort of what I would call the lifestyle interventions. But again, most patients are very, by the time they've gotten to me, they've recognized what their triggers are and they avoid them,
Yeah.
and they eat their 3 meals a day. And so, but that's usually where I start with people.
Perfect. And then what are the typical kind of, one thing that I've also appreciated in migraines, headaches, is sometimes patients have barriers to care. So to see a specialist, someone with specialized training in migraine headaches, there's obviously like long waiting lists and things like that. And what I really appreciated during my pain fellowship was the waiting list to see a headache specialist was 1 to 2 years, depending on where you are. And I saw a lot of patients develop headaches or medication overuse headaches.
Big time.
Can you talk to us about what medication overuse headaches are, and what are the things that patients should look out for?
Yeah.
And kind of discuss with us like what are the barriers, what your recommendations to patients are who are looking to see a migraine specialist and having trouble finding one.
Yeah. So another really good question. So there is this strange paradoxical thing that can happen, particularly in folks who have migraine headaches. So if you and I don't have migraines, and I don't think you have migraines either. And so if someone like you or I were to take ibuprofen or acetaminophen every single day for the next 3 months, we might get a gastric ulcer, but it's not going to lead to any kind of medication overuse headaches for us. But there's something about the pathology of migraine that predisposes patients to developing this concept of what's called medication overuse headache. And so the Canadian Headache Society and different headache societies will put an exact number on it. And so we generally will recommend for patients to use things like ibuprofen or Tylenol less than 14 or 15 days in a month.
Mm-hmm.
And then for our triptans like sumatriptan or rizatriptan, we put that day at less than around 10.
Mm-hmm.
Because again, there is this paradoxical thing that can happen where if someone who has migraines takes ibuprofen, which is Advil, every single day, for reasons that are not entirely clear, they end up getting more frequent and more severe headaches, which again wouldn't happen for someone who doesn't have migraines, but
Mm-hmm.
for this migraine population, unfortunately, you end up in this sort of negative feedback cycle where you have a headache, so you take the ibuprofen, but taking the ibuprofen every day leads to more headaches, and you take more ibuprofen. So you end up going through this sort of downward cycle of requiring more and more Advil or ibuprofen.
Okay.
Which then, we don't have to get into it now, but that leads into the discussion of, well, are there medications to take when you have a headache that would not lead to medication overuse headache? And the answer is yes. Some of the new G-PANTs out there, like ubrogepant, is actually a medication that you take when you have the headache, like the same way that you would take a triptan, like you take a sumatriptan, or you take or diclofenac when you have the headache. So we call that acute treatment of headache.
And that's really important, right? So some of the patients that would have migraines would be like, oh, I think I'm having a migraine, but I'm not really sure. So they would wait for a few hours, and then, then the triptan's not as effective.
Absolutely.
And right, so that's part of like the management and counseling, and you give those small bits of information, specialist-led information to a patient, and it can really have serious implications and improve their quality of life and improve their trajectory of the migraine, right?
Agree. And I like what you mentioned about taking it sooner rather than later. So the advice I give to all my patients who have migraines are, particularly with medication like ubrogepant. So ubrogepant is a G-PANT. It's to be taken like a triptan, like ibuprofen or diclofenac, but has not been shown to cause medication overuse headache.
Right.
And so my advice to my patients is, at the earliest sign that you're going to have a headache, whether it's neck pain or you're yawning, Most patients are able to, if you really ask them and dig down to it, are able to identify not necessarily aura, but prodrome symptoms
Yeah.
that precede the migraine. Again, yawning, neck pain, things that we wouldn't normally think about that precede a headache. Mood changes is another one. Oftentimes folks will notice that they get significant mood changes in the day or so, or even a few hours prior to the headache. So I always tell patients, at the moment that that happens, take your ubrogepant, take your Gpant, to try and get ahead of the headache, because like you said, as the headache progresses throughout the day, it's going to get harder and harder to abort.
Okay.
Yeah.
So really, like, we've talked about a lot of different types of medications. We've talked about some supplements, about lifestyle changes. All these things work in synchrony together for a patient to reduce their amount of migraines and reduce the intensity of their migraines.
Correct.
And really, it's the intensity which really leads to disability, and the frequency which leads to disability. So really, we want to get on top of their migraines, reduce them. So if someone who has migraines, if they have migraines from, let's say, a young age, is there ever a chance when they will go migraine free? Is that a possibility for some patients who have been suffering for so long?
It's another really good question, and it goes in line with some of the questions that patients ask, which are, do I have to be on these medications forever? Is this a forever disease? And for the most part, what I tell patients is migraine is a chronic neurologic disorder. I would think of it like hypertension or dyslipidemia, sort of diseases where we expect patients, not expect, but it's anticipated that patients are going to be on their statin for the rest of their lives, or on their antihypertensive for the rest of their lives. And so I always tell patients that I hope that this is not a lifelong disorder. And there are certainly going to be periods of times in their lives where the headaches are either going to be better or worse, particularly in females who either become pregnant, or once they become perimenopausal or reach menopause, headaches can either get worse or get better.
Yeah.
And so the answer to your question is, we do look at migraine as a chronic neurologic disorder, the same way that I would see hypertension and dyslipidemia as a
So you're
chronic
essentially
disease.
setting realistic expectations for your patients, right?
Try to. And again, I'm not telling people that they're going to be suffering with these deadly headaches not deadly, because migraines are not deadly, but they're going to be suffering with these awful headaches for the rest of their life. I tell them we're going to work to get this under control with our lifestyle interventions and medications. But there may be a time in the future that they may be doing very well even without medications or interventions.
So as a medical director here, I see a lot of, I do all the triaging consults, and I see who, certain questions that our common referrers send us. And we have some excellent family physicians who send us patients here. And often questions are about, because, the family physicians do a great job of getting them on, prophylactic medication, educating them on the importance of things that we've already talked about taking your medications acutely, not letting it linger, identifying your prodrome symptoms, and acting, reactively, right? Or sorry, acting proactively, I should say. A lot of the questions we get sent from our really great referrers here is, some interventions, and one of the common ones is Botox, right? So sometimes I'll just see some referrals with patient has migraines, known chronic migraines, is interested in Botox.
Yeah.
So what's your kind of the patient pathway for this, and what are some of the the coverage for migraine? Because that's a very common question.
Big time.
Even our secretaries actually get that question. Patients will call in and ask these questions to our secretaries. So I'm hoping you can close the loop on that.
Yeah. So I'll use this time to sort of plug the new Canadian Headache Society guidelines on preventive medication for migraine. They're actually just released, and they're excellent. And the previous guidelines, at least from the Canadian Headache Society, I think were out in 2012. And so really good set of guidelines that I was able to go through recently, with a lot of new information on there. And of course, onabotulinum, or Botox is a trade name, is certainly a first-line option for folks who have chronic migraine. And again, the chronic migraine is that very specific 15 headache days in a month,
Right.
with 8 being migraines. So once a patient is in that chronic migraine territory, that's when Onabot or Botox is sort of a first line therapy for chronic migraines. The issue is that is the coverage, like you say. So for folks who have private insurance, whether it's through work or their spouse, they generally will need to try 2 preventative medications
Mm-hmm.
before their insurance will cover the cost of the Botox.
Mm-hmm.
And then for folks who have ODSP as their insurance, I believe it's 3. So they need to try 3 preventive medications before the medication or the Botox cost will be covered. So,
Mm-hmm.
I mean, unfortunately, it is prohibitively or can be prohibitively expensive. But luckily, we actually work with some of the folks at AbbVie.
AbbVie is what?
AbbVie is the pharmaceutical company that manufactures Botox.
Okay.
And so we have some, and I think most headache providers have sort of contacts within AbbVie. And so generally what I'll do for most of my chronic migraine patients who are interested in Botox is I reach out to the folks at AbbVie, the sort of manufacturers of Botox, and I say, hey, can you help this patient work with their own insurance provider to determine whether or not they could get coverage. And so they have a liaison that directly works with the patient. They'll call to my patients, they'll send them an email, they'll text them, and they work together to find the best way to get the coverage.
Okay,
Yeah.
that's very good information for even the docs that work here and patients and just the public in general.
Yeah.
Now, I know there's always new things coming out. There's a lot of research in migraine headaches. There's a lot of investment by pharmaceutical companies. You talked initially about G-pants. Are there any other kind of migraine therapies that you're excited about? Things that you can offer some of our patients with really resistant chronic migraines here at Afiya?
Yeah, for sure. So we talked about the G-pant, or at least I talked about one G-pant, which is ubrogepant. There is another G-pant called atogepant. So same category of medication, except atogepant is used on a preventive basis. So we didn't really kind of talk about acute versus preventive, but in short, acute medication is the one you take when you have the headache.
Right.
That's things like sumatriptan, ubrogepant, diclofenac, ibuprofen, acetaminophen, or any combination thereof.
Yeah.
And then there's preventive medication. So the goal of preventive medication is to prevent migraine frequency and severity, which raises the question of when does someone sort of meet criteria to get preventive medication? There isn't a hard and fast rule, but I would say somewhere around 4 migraines a month.
Mm-hmm.
If you're in that territory, is when I start to think about offering preventive medication options. Within the preventive category, there's a whole host of different categories. There's the antihypertensives, candesartan, the beta blockers. There's the tricyclic antidepressants, amitriptyline, nortriptyline, and a whole host of other medications. Long list, won't get into it now. But going back to your question of any other new medications on the horizons, and the answer is yes. There are monoclonal antibodies that target CGRP, which is found to be implicated in migraine. And I apologize because I'm going to use all the trade names because the actual drug names are very long. But medications like Vyepti, Aimovig, Emgality, these are often medications that are self-administered or infusion.
Mm-hmm.
So one of these medications is, you go in once every 3 months, you get an infusion, and that's it. You go in every 3 months, you get the infusion, and that's the medication you're using preventatively for your migraines.
Mm-hmm.
There's also self-administered, almost as if you're taking Ozempic or insulin. There's self-injecting pens that one could use as well on a monthly basis, rather than taking medication on a daily basis.
And so coverage, that's the next question.
Coverage is another issue. Again, when it comes to the monoclonal antibodies, insurance coverage is not as sort of black and white as the Botox situation. Every insurance company is a little bit different. Most insurance companies will require you to try one or two preventive medications before they go ahead and fund your, whether it's Emgality or um, Vyepti. But again, I don't want to make a blanket statement because every insurance company is a little bit different. Suffice to say that these medications are new. They are unfortunately expensive, but talk to your headache specialist, and they can help you work with your insurance provider if you have one or not, about getting you coverage.
Talk to Dr. Saikaley,
Yeah, there you go.
essentially,
There
right?
you go.
So, we've given, talked about a lot of things. We've used a lot of medical terminology, and
Yeah.
unfortunately, we can't get around this medical terminology with all the, important nuances of migraine headaches. It's a very complex, chronic neurological condition, as you've stated. You wear two caps. You work in the emerge, and you also, work in interventional and chronic pain.
That's right.
How has your migraine management gotten better after you've, done additional training in pain medicine?
Yeah, so it changed a lot. I would say before I had any exposure to migraine in residency, I was treating every migraine. At first I would make sure this is not subarachnoid hemorrhage or some kind of scary, dangerous cause of headache. Once we've ruled all that out, I basically had the same approach for every single migraine patient I saw. Again, this was before I had any exposure to migraine training in residency. So everyone would get a liter of fluid, maybe some dexamethasone, some ketorolac or Toradol, and metoclopramide or Maxaran. But since my training in residency, my approach has been quite different. So the first thing I'll offer patients, and this is something we haven't talked about yet, but the first thing I'll offer someone who's coming into our emergency room with a really refractory migraine is nerve blocks. So essentially using local anesthetic and nothing else. Same stuff you get at the dentist to freeze your teeth. And I tell them I would put it over very specific nerves around the head and the face with the hopes of aborting the headache here and now. So I always offer them that in conjunction with the other medications that I had mentioned, Toradol, metoclopramide. And a good 50% will say yes. The other 50% will say no way, no needles in my face and head, which I don't blame them. But in my anecdotal experience, I don't think there's been any RCTs done on any of this kind of stuff, but in my anecdotal experience, in the vast majority of the time, I'm able to have the patient discharged from the emergency room before the patient even, so this is what I'll do. I'll give them the nerve blocks, but before I order the nerve blocks, I'll order the nurses to give Toradol and Maxaran. But before the nurses even get to the patient, I will have done the migraine nerve blocks, and the patients are like, oh my God, I'm 100% better, obviating the need for any ketorolac or Maxaran. So before these patients even get any IV, IM, or oral medication, I'm able to do these nerve blocks and really significantly reduce the amount of time that they spend in the emergency room, which has been a real blessing. And then on top of that, as patients' migraine is relieved in the emergency room, I will always ask them, do you have a family physician? How many migraines are you getting a month? I'll ask some questions around the migraines. And I will often send them home from the emergency department with at least an acute treatment for their migraine, whether it's sumatriptan or Ubrelvy. I will at least send them home on that, and will often urge them to either follow up with their primary care physician or consider seeing a headache specialist.
So that's a really interesting. So, additional training has been beneficial. Obviously,
Big time,
you've really helped, patients in the community who are suffering from migraines, and I'm sure you've helped people in your department, who don't have specific chronic pain treatment as well. So that's really wonderful for care. You also bring up a big important thing is, patients who suffer from migraines have to, unfortunately, go to emerges because there's many barriers to seeing a specialist. There's even barriers to having a family physician or even seeing your family physician. There's an unfortunate state of our healthcare. And so what's kind of your advice to patients who, are kind of stuck in that middle zone where they don't have the appropriate specialists around, or the waiting times are too long? how do you kind of counsel and manage, and how do you give hope to patients?
Yeah. I mean, I wish I had a great answer for you, because I agree with you in that access to both primary care and specialty care, particularly in Ontario, is not the greatest at the moment. So particularly for folks who I see in the emergency department, I always offer to see them myself. And I think that some of my colleagues at the emergency department where I work also know that I see chronic pain and headache patients. So I always urge them to feel free to refer to me as well. I'm happy to see all these patients. Our wait times are pretty good here.
Yeah.
And so we're often able to see patients within days to weeks. So
Yeah.
yeah.
So we need more Dr. Saikleys out there, right? Well, we've talked about a lot of things.
Yeah.
And if you could give one last message to our patients out there in the community suffering with migraine headaches, what would you tell them? What would you give, how would you give them hope?
Yeah. I would tell them that it's 2024. There are a lot of new migraine treatments out there. It's a cliche, but it's a marathon, not a sprint, meaning it might take some time, but with all the different interventional and nutraceutical or supplements and medical sort of therapies that exist today for migraine, we're bound to find something that will help you. Again, it's just a matter of, unfortunately, a bit of trial and error. But I'd really urge them to speak with their family physician or reach out to a headache specialist if they have one in their community.
That's amazing. So we'll wrap up now. If anyone's suffering from migraines, please, consider seeing Dr. Saikaley. He's clearly very passionate about this, and hopefully we can make a difference in your lives.
Thanks for having me on the show.
All right.